Hi, I'm Jon Roffman, Managing Principal of ZS's Oncology Vertical. I'm here at ASCO 2019 with Dr. Julie Vose. Dr. Vose is the head of hematology and oncology at University of Nebraska Medical Center. She also served as a former ASCO president, as well as on the FDA's Biologics Committee and ODAC. Dr. Vose, I'd love to talk about precision medicine. Are most patients at your practice today tested with some sort of molecular test?
Typically, no. Certain diseases, certainly, we always do that for if it's a known entity as far as choosing therapies. Mostly, it's used for patients who have gone through their standard therapies and then it hasn't worked, and they go on to a secondary or tertiary therapy for solid tumor patients. However, I think that again, it has to be confirmed that actually methodology actually works before it's taken out into clinical practice, and that's the part that's still missing.
Do you envision in the future that more testing will be done upfront rather than as a last resort?
Yeah, I do think that in the future that it will be done, but it needs to be validated and confirmed that that's the appropriate thing to do, because it is costly. And in the end, it could be less costly if we do that and can choose a therapy based upon that actually helps the patient. So you have to look at the big picture.
Are there specific tumor types where you do test every patient?
Certainly for lung cancer, they're always tested. For breast cancer, they're always tested. So some cancers, definitely the upfront testing is already done. For other cancers, it's a bit more, is there a hereditary reason for that patient who's 40 and has colon cancer, that type of thing. I think as we expand our knowledge more and more, this testing will be much more available and useful.
How do you see that playing out in terms of getting more patients tested as a way of getting more data and evidence into the system?
Right. So I think from the physician standpoint, we would love all the patients to be tested. It's more of a cost issue and a risk-benefit issue. So if we could get the testing paid for so that we could get the data and then do the analysis, that would be great, but that has to come from somewhere, and lots of times we can't get the approval from the insurance company for the patient to get the testing done, and then they're caught with a huge bill. So it's really a problem, a catch-22.
Mm-hmm. And with the recent approval of some pan-tumor therapies, we saw Vitrakvi approved for NTRK fusions, and of course Keytruda for MSI high.
Yes.
How do you think that will play out in the future? Will we see more of these pan-tumor approvals, and how will we test and identify the right patients for those situations?
Yeah, I think that's actually ingenious to be able to do that, and a way to get a very important drug approved for multiple patient populations. So I think that is an approval process that we'll be seeing more and more of in the future, but of course the clinical trials have to analyze for that and test for that and to be able to do the appropriate patient analysis. So I do see that as an alternative pathway that will be very important in the future.